Hello, my name's Nick Human. I'm Chief Executive at Ipswich Hospital. There's so much that we can't give to patients. There are so many of our patients that come to us with all sorts of complex, difficult conditions, many of them at the end of their lives as well. The only thing that we can give to our patients is time. It's wrong of us to take away any amount of time from anybody's life, any time that they can't spend with their loved ones, with their families, in their place of residence when they've been ill, is doing them a disservice. The fantastic work that we've done in the hospital for the last few years to give people their lives back earlier, I think we could go even further. How often are people here when they don't need to be here? How often are we admitting people into hospital when they don't need to be admitted? The work that you do on the ward round is absolutely crucial to that. Many people who leave our hospital don't have long to live. What right have we got to even take half a day away? So what I'm asking today is that we look differently at patients, we look differently at families. We ask patients, how well do you need to be to get you home, not how well do we want you to be? What is it that you can cope with in your home so that we can support you to get to that position and then get patients home as soon as we're able. So thank you for all the work that you do every day to give people their lives back, but let's see whether or not we can shorten the time that we take people's lives away by keeping them in hospital and giving their lives back even sooner. Thank you.
This hospital is known throughout the country for managing patient flow when other hospitals are struggling. The red to green processes have kept occupancy at a level that has made sure that we can keep flow and our patients safe. The success of this has been down to you, all of you. But we now find ourselves struggling. Our length of stay has gone up and we have had to open more beds, which we are finding difficult to staff with nurses, doctors and therapists. This situation is mirrored across the country. I'm sure, like me, you have heard it on national news. Like many places, we could continue to battle against the pressures, work harder, get more exhausted and provide substandard care to our patients. But that is not the Ipswich way. Team Ipswich are fastly getting the reputation of thinking differently about problems we face and doing something about it. So that is what we're going to do. We are going to do three things. Firstly, we are going to review all our patients at the front door. That's the whole MDT team reviewing every patient, setting an expected date of discharge and setting a pathway, a red, green or amber pathway, of which you'll hear more about in a moment. Secondly, we are going to concentrate on our board rounds and our red to green processes. And thirdly, we are going to have a weekly deep dive review of all those patients that are delayed in our hospital. Today though, we are going to talk to you about number 2, board rounds and red to green. You are now going to hear from a range of colleagues to tell you just how we're going to deliver this programme. Thank you.
So key things as therapists we need to remember at the board round. We need to challenge our decision making at every step, as we owe it to our patients to get them home as early as possible and give them back their time. Any patient who's been admitted from ED or EAU will be on either a red, amber or green pathway. This will be shown by a red, amber or green sticker at the front of their notes with an EDD on it. When the patient is medically stable, we need to be asking what is stopping this person from going home. Functional fitness does not mean that the patient needs to be back to their previous level of function, but they do need to be able to safely access food, bed and the toilet. If there is a delay or we are waiting for another service to respond, it is our responsibility to be chasing or escalating the issue. It is also our responsibility to know what is available for patients to access both within the hospital and in the community. For example, the inpatient reablement ward and early supported discharge services. Reinforcing the functional charts at the head of the patient's beds and the patient's ability for reablement on the ward is important to discuss, as this will help to prevent the deconditioning. Home, or their pre-admission place of residence, is always the place we should be aiming for our patients to return to on discharge. We should also be exploring all avenues of support for the patient's care on discharge, so from their family, from the local community, prior to any discussions being held about involving care agencies. Also, the discussions that have been had with the patients and their family and carers in setting early expectations for discharge need to be shared at the board round. So the key message is we need to be challenging ourselves, challenging each other, and so learning together.
Right, so board round, guys. Are we all right?
Yes,
good
good
morning. Good. Right, so A1, Sarah Jones. So she's been in hospital a couple of days now, came in with cellulitis. Medically, we're still on IVs at the moment, so still need to carry on those antibiotics, and I'm planning, hopefully, to get her onto orals tomorrow, so we'll be making her medically stable for discharge tomorrow.
We saw her this morning and she's mobilising well with a stick which she was using previously. She's walking about 4 metres currently. Ideally at home we'd like her to be mobilising 6 metres, so if you on the ward could be mobilising as much as possible. If she needs to go out to the toilet, get her to mobilise rather than bringing her a commode. Once she's able to do that, I'm confident that she'll be functionally fit for discharge, so I'd imagine we'll be signing that off this afternoon. I've spoken to her husband, I've given them a leaflet about community resources if they do need any help once at home, if they've got any concerns.
Okay, so what I'll do is I'll speak to her husband and just inform him that we're going to do the simple discharge and restart the care for tomorrow afternoon.
Okay.
And I'll ask him to come and pick her up.
Okay, so simple reinstatement,
Yeah.
and our discharge date's the 4th.
Yes.
Yeah.
That's all right.
So moving on to
so-
side room B,
Yes.
guys. George Green. So he's our gentleman who had the fall and with the hip pain, and we were just keeping an eye on his pain control. But actually, we'd said he was medically stable. You guys were happy with him.
He's
He's a
functionally
bit of a
fit.
delay, isn't he?
He is, yeah.
Have we progressed any further?
He's got care with Home First can start on the 6th, which is in 3 days' time, but I've contacted CAT Plus. They've actually got capacity to bridge his care. They can start this evening. He's going to go home with BD care, so they're happy to start this evening.
Yeah, and I've booked transport via Bed Bureau for 2 o'clock. And if you could just make sure that the valve and CTAs are sorted too.
And we've been happy with his pain when he's been mobilising.
Great, and I think that the juniors have already done the discharge summary, haven't they? Because he's been a delay for a few days
Yeah, it's
now.
done.
Yeah.
So great. So we're actually going to be going home with Cat bridging the gap.
Yes.
And then in overall care.
Yes.
Great stuff.
Nothing.
Okay. So C2, Joyce Brown. So lady who came into hospital with a community-acquired pneumonia on top of her metastatic lung cancer. And palliative care team have been involved with this lady in the community, and it does look that we're sort of having a chat with the family, and she is more palliative approach now. We just weren't sure how much the residential home are going to be able to manage that. So medically, I think we're happy that we've got a plan with the family and with the lady herself. So we're happy.
I've spoken to the residential home. She's all care in bed at the moment, isn't she? They haven't got a profiling bed or the pressure relief that she requires. Residential homes do have their own budget for equipment, but we can lend them equipment for up to 30 days. So I've spoken to the IDPT nurses. They've done their assessment. We're going to put a joint order in for a 4-hour delivery for Mediquip and lend them the equipment, which will go in this afternoon.
Lovely.
So
Okay.
Transport-wise, do we know how we're getting this lady home?
Yeah, I'm going to book transport, but I'm going to wait. I need to confirm the equipment's actually
Yes.
in before I can. I mean, I can preempt the transport, but I just want to make sure the actual
yeah.
equipment is in place. So,
Yeah.
And she's got a catheter.
Yeah, I'm going
so-
to do district nurse referral for catheter care, pressure care and palliative care.
Lovely. Thanks, Vicky. Okay, and then John Smith in D2. He's the gentleman who came with urosepsis and delirium. He's actually only just come from Grantham, so he's only just landed on the ward. I understand at the moment he's still on intravenous antibiotics, and we're being a little bit limited because of the sepsis in how well he's been. From a medical point of view, I think we need to see that he becomes hemodynamically stable, that he's afebrile, and that he's probably able to eat and drink, and then we can convert him from the intravenous antibiotics to oral. So I suspect that he's going to be medical for probably another 4 days. How's he been with you?
We've tried to sit him out, but he's still been really confused and he requires the assistance of two.
Right, so we've got quite a way to go with this chap.
Yeah, he lives with his wife. He had no previous care, but in preparation, what I'll do is I'll speak to his wife to get a really clear picture of the home situation. Also, ask her how much support she's able to give, or whether there's anyone else that can support them when he first goes home. But I do think he's going to need reablement care, and I would have thought we're probably looking at discharge to assess pathway 1, where he'll go home with a more intensive reablement package.
Okay, so I think we're going to need section 2, aren't we?
Yeah.
And
happy
our
to do
earliest discharge date, I think, taking all that into account, is probably at least a week for
Yes.
this gentleman.
Yes.
So if we set that now, so that's going to be the 8th. All right, and then we'll just see how we're progressing along that tomorrow.
Lovely.
Okay.
Lovely. Thank you.
I'll do the section 2 if you let me know what for.
Lovely. Okay,
Yeah.
I'll do that.
Lovely.
Thank you.
Thank
Thanks
you.
very much. Thank you.